Good day, and welcome to Dental Direct. In today's video, we'll be discussing the stages of pulpal pathology and what these stages mean for us as clinicians. When we discuss pulpal health, we can broadly classify the pulp as being either healthy, inflamed, or dead. Pulpitis is the term used to describe inflammation of the pulp. Pulp necrosis is the term used to describe death of the pulp. When we look at pulpitis, we know that inflammation is a perfectly normal process in our body, as it responds to many different factors such as infection, trauma, or in conjunction with healing. Inflammation can occur within the pulp as well. The problem with this is that the pulp is a confined space, and inflammation creates pressure buildup within the pulp due to an accumulation of fluid from sustained vasodilation of blood vessels within the pulp. The most common cause for inflammation of the pulp is by bacterial invasion, such as those involved with dental caries. When we look at pulpitis, we classify it as either reversible or irreversible, and the names themselves may already be giving you an idea as to what they involve. In reversible pulpitis, pain is present during stimulation such as call testing or percussion testing, but this pain is sharp and usually short duration, generally for only a few seconds. In other words, the pain doesn't linger. We would consider reversible pulpitis as the early stages of pathology of the pulp. Reversible pulpitis can still be managed relatively conservatively if the causative factor is removed, such as an active carious lesion being restored, with the infected hard tissue being removed. Irreversible pulpitis is a more severe form of inflammation within the pulp. Pain is present during stimulation, such as call testing or percussion testing, but this pain is long-lasting and it lingers. Initially, there is a short duration pain as well that is similar to reversible pulpitis, and this lasts a few seconds. But then there is a sustained, longer-term pain that tends to linger and is a dull, throbbing pain. This can be anywhere between a few minutes to a few hours. There may also be pain when the patient lies down or bends over, and this is from change in the intrapulpal pressure acting as a stimuli within the pulp, and this is usually only associated with irreversible pulpitis. So the main difference between reversible and irreversible pulpitis is that reversible pulpitis is a short duration, sharp pain, while irreversible pulpitis also has that initial sharp pain, but tends to have a longer lasting, throbbing, dull pain as well. If left untreated, irreversible pulpitis is likely to lead to pulp necrosis, but the pathway to this may take several forms, where the pulp may even appear asymptomatic. So someone may think that the toothache they have is getting better and that they don't need to see the dentist anymore, but unfortunately it's just getting worse. Pulp necrosis occurs as the pressure buildup within the pulp becomes so great that it collapses blood vessels. This leads to any cardiovascular supply to nerves and pulpal tissue becoming compromised, and since blood supplies oxygen, a state of anoxia will occur, and since the tissues aren't getting oxygen, necrosis will occur within the pulp. So these are the main processes for how a tooth can transition from healthy, inflamed, and eventually dead. Unfortunately, a pulpectomy is indicated if a diagnosis of irreversible pulpitis is made, and this is the removal of the whole pulp. Leading on from what we've discussed, apical periodontitis is the formation of an inflammatory lesion at the apex of an often chronically infected tooth, such as that of a necrotic pulp. Radiographically, we would see a radiolucent abnormality at the apical area of a suspected tooth, and this can be either a cyst or a granuloma. You can't determine whether this radiolucency is a granuloma or a cyst until you send it for histological analysis. If we ever see apical periodontitis on a radiographical examination, a root canal therapy is highly indicated. We want to resolve this lesion as soon as possible, and often removal of the causative factor will result in a resolution of the lesion. We would remove the causative factor by doing root canal therapy, and therefore inhibit bacterial invasion into the apical area. I should mention that the implication of bacteria towards the etiology of apical periodontitis is still limited, but it is still a consideration for the formation of apical periodontitis. So now that we have a good foundation for the theories behind pulpal pathology, let's move on to looking at some clinical considerations. Clinically, we use investigative methods called vitality testing to help determine the state of a tooth's pulpal health. Vitality indicates that there is still a response to stimuli from a tooth's pulpal sensory innervation. Non-vitality indicates that there is no response to stimuli being detected from a tooth's pulpal sensory innervation. Using these concepts, we can clinically investigate the health of the pulp to gauge what stage the pulp is in. If the tooth is responding to stimuli we apply and no pain is felt, the tooth is vital, and the absence of pain indicates health. If the tooth is responding to stimuli we apply, but there is pain felt from the stimuli, the tooth is vital, but the pain indicates the tooth is in a state of pulpitis. If the pain from the stimuli is short-lasting and it's a sharp pain, reversible pulpitis is indicated. If the pain is longer-lasting after the initial short, sharp pain, irreversible pulpitis is indicated. If the patient can't feel the stimuli being applied and doesn't feel pain, the tooth is non-vital and pulp necrosis is indicated. There are 3 common pulp testing methods for vitality testing, and these include thermal testing, percussion testing, and electric pulp testing. We would typically try to use all or at least 2 of these methods to help give a definitive diagnosis for pulpal pathology. Thermal testing simply involves placing a warm or cold stimulus on the tooth. Cold sprays are easily used and can be applied to a cotton bud to place on the tooth. Percussion testing is simply tapping the tooth with an instrument. We would typically use the broad end of an instrument, and you'll want to be gentle as there is no need to be so powerful that you crack a tooth. The theory behind percussion testing is that you're creating fluctuation of the intrapulpal fluid, and that movement of intrapulpal fluid will cause sensitivity in the nerves. And as we said before, inflammation results in pressure buildup within the pulp. And as we said, electrical pulp testing, or EPT as it's commonly referred to, involves using an electrical circuit formed through the tooth to test vitality. The tooth is dry and a surface medium such as toothpaste is applied. Most kits will have a numerical reading to give an objective reading for better comparison. The theory is that electrical current moving through the tooth should stimulate nerve fibers within the pulp. But if there are no nerve fibers, as they have undergone necrosis, then there will be no sensation felt. So, if the maximum current is reached, no numerical value will be given. and instead a value saying negative will be shown. This indicates the tooth is non-vital according to the testing kit. So to conclude, we've defined the simple stages of pulpal health and pathology. We've looked at why these pathologies occurred, and we've looked at how we can determine pulpal pathology clinically using diagnostic pulp testing methods. Before we dive any deeper into endodontics, I'll end the video here. Thanks for joining us in this video from Dental Direct. In the meantime, protect that smile and live a healthy lifestyle.